welcome back to Pain Points. I'm Dr. Jake Caylor, and you're joining us today from Round Rock. This is my actual office. I'm not working out of my closet this week, thanks to the Texas ice storms here in Austin, Texas. So thank you so much for joining me again. This is our weekly kind of video series that we're going to be doing, where we're focusing on patient education so that we can advocate for ourselves, so that we can navigate the healthcare system, which is extremely challenging. So today we're going to be really talking about what is a pain doctor? When should I see a pain doctor? What is pain medicine? Is it pain management, pain medicine? What are these things? And so I really want to talk about today, what does a pain doctor do, and how do we come to our, approach our decision tree where we can say, okay, we're going to go down this pathway or that pathway. Again, we're trying to think about the patient as a whole, and we're going to be continuing on this theme of altered biomechanics. And really what that means is when you have pain, it has consequences, and it changes the way we walk, sit, stand, twist, lift, all these things. So thanks so much for joining me. As always, this is an interactive presentation where I get to actually work with patients and other people who may not be my patients. So you might be coming at me from Seattle, Washington, or New York, and wherever you are. The goal is really to hope to bring more access to these therapies so that you can speak to your provider, or you can speak to your family about them. So thanks again for joining us. So today, we're going to be talking about what is the historical approach to pain. How has pain typically been treated in the past? And this is the field of pain medicine. And that's what I mean when I say pain medicine. It's like internal medicine. This is our field of study. And so I'm not talking about pain medicines as in pills. And so I really want to talk about how things were done previously and kind of how we do them now. I want to talk about Pain Pathways 102. Last week, if you haven't seen it, we talked about what are some pain pathways. I want to talk about the importance of continuing to have pain and not treating it, because there are ramifications of that. So we're going to talk about that today. And then we're going to talk about, when should I see a pain specialist? What is a pain doctor? Why should I see a pain doctor if I'm having changes in function? And that's really because our field has evolved. So we're going to get into that. And then we're going to talk about our procedure spotlight today, which is going to be the facet joints. And you're going to have a little bit of a snippet of anatomy in there as well. So thanks again for joining me. When we think about our job as pain physicians, we really are pain and function physicians. Our goal is to both diagnose and treat different types of pain syndromes. And there's a number of different syndromes out there. And we use pain patterns to help us identify, okay, is this more of a mononeuropathy, meaning one nerve's being affected, or is this a plexopathy? Is this a grouping of nerves, that spider web of nerves that's been kind of irritated? Is this a focal process? Is this a global process? These are things that we're always working through. So we always have to take those three things and be able to put together to figure out what's going on with the patient or create a differential diagnosis. That first thing being the patient history. What's your story? When did your pain start? Where did it go? The second thing being imaging studies that we have. And the last thing, and my favorite, is the examination, putting your hands on the patient and understanding where is the pain, and trying to put these three things together to be able to say, this is where we're going to go. Historically, we kind of treated pain as, okay, we're going to try all of the not the easy stuff, but the less risky stuff up front. And so we would try things like rest, ice, compression, and elevation. And that's still the gold standard. That's not that we're changing that. It's we want to be thoughtful about when is it appropriate for us to jump in and alter the body's ability to take care of itself. From there, we would try, okay, let's try some topical things, some Voltaren gel, some diclofenac cream, whatever it is, some over-the-counter Tylenol, ibuprofen. And then from there, we said, okay, we'll send you to physical therapy, chiropractic, massage. And the goal of this was really to give the body its ability to heal itself. And we kind of treated all pain in this way, where we say, okay, we'll let the body treat itself, and we'll take over when that fails. And then after that, we would say, okay, well, that didn't work. Let's put you on some medications. And we're going to try either opioids, neuropathic pain agents, the serotonin and norepinephrine class reuptake inhibitors, really focusing on that neuropathic pain. And we try this multimodal regimen, meaning multiple different types of medications to take care of a whole pain complaint. And then after that, we'd say, okay, now we can try injections or procedures to correct the pain. And if everything's refractory, then we'll send you to surgery. And today I really want to challenge this paradigm because I think there are consequences to it. Because if we have the ability to fix something, like we were talking about with biomechanics, it's not just the longer your pain has been around, it's how has that pain affected how you change the way you walk, sit, stand, twist, all these things. And that's the world of biomechanics. So there's consequences both in the central nervous system as well as from a biomechanical perspective. So what's the problem with this last approach? Time. Time is really my biggest issue with waiting too long, right? And there's an appropriate amount of time to wait, but waiting too long can cause these things to really ingrain themselves in our life. It doesn't treat the problem. Waiting doesn't always treat the problem, and that's not the appropriate amount of waiting. Again, this is if we give things 6 months. Let's say by the time you have 3 months, you have chronic pain. Okay, now you go to your primary care physician. They try some things. Now, by the time 6 months is around, your pain has been around for 6 months, and that's 6 months of altered biomechanics. There's consequences to that. And now you're referred to a pain physician, which might take you another month to get in. So by the time we actually start to try to address the issues, or whether that's surgery, injections, whatever, we're not just dealing with that primary thing that happened 7 to 8 to 9 months ago. We're dealing with all of the cascade that's happened with afterwards. Allowing pain to continue also secures these pathways in our brain and spinal cord. And then the neurologic system is plastic. And this is what we were getting at last time when we were talking about, sorry, I have a really squeaky chair today. Last time when we were talking about pain pathways, the neurological system, the central nervous system, can remember these things and upregulate them. And we're going to talk about that here. So again, altered biomechanics playing a role. And so why does it matter the length of time that you have pain? Well, we talked last week about how nociceptors carry pain information into the spinal cord. Those go up to the brain through this second order projection neuron. There's this little thing called an interneuron, and your brain has the ability to control this information through descending inhibition. Well, what happens if we wait too long? Well, your brain and spinal cord adapt to this. And what happens is this thing called peripheral and central sensitization, whereby you continued stimulus, so continued pain signals to the brain, reinforce that circuit and make it more difficult for our brain to control the information. We talked last week about how your brain is constantly controlling the amount of information to it. Well, if it weren't, we'd be on constant sensory overload. And that's really one of the things that we see with chronic pain is these sensations are reaching the brain when our brain should be controlling them. So it happens both locally out in the tissue. So if I have finger injury, that repetitive inflammation there causes problems here. It causes issues over time in the spinal cord. And it actually causes all of this synaptic reorganization in our brain and spinal cord that will lead to chronic pain. Now, some people develop chronic pain and some people don't. We'll get to that down the road in a few series. So what does a pain doctor do? And I would say the biggest thing that we do as diagnosticians is evaluate all of the data and try to formulate a diagnosis and treatment plan that is going to allow us to rule out different pathologies, as well as treat those different areas of pain. And that's why we're trying to more quickly come to a solution to the pain as opposed to managing, right? Because while we are doing management in a way, we really are more quarterbacking as far as distributing where we're going to be spending our efforts in order to resolve the pain in the most timely manner. And this can include watchful waiting. Like I said, there's nothing wrong with waiting. It's monitored waiting. It's having a plan in place so that if waiting fails, we're not now waiting another 3 months before we're doing something about it. So it's about creating a plan. And physical therapy, chiropractics are part of this. It includes workup, labs, diagnostic imaging, other studies that we're doing, evidence-based medications, and then complementary and alternative techniques. And in addition to that, interventions such as procedures. And yeah, at the end of it, surgery might be the right option. But sometimes the thing that's most important is having a team of healthcare providers taking care of you. And that might mean sending you to a surgeon so that we can collaborate and come up with a plan together. And that might mean surgery, that might not mean surgery. The goal is actually functional restoration and resolution of the pain. So why is this? Why is it that the pain doctor is treating not just pain, but we're also kind of central to this idea of improving function, numbness, tingling, all these other sensations that happen? And it's really because historically our PCPs who used to have the bandwidth to be able to do this, they don't have that bandwidth anymore. And there are more demands on the healthcare system for primary care or for pain specialists as well as primary care physicians that we have to rely on a team approach. We can't manage all of these problems together. And I'm going to talk about that here in a second. With regard to pain and function, the pain physician is, we're not just treating pain, we're also treating function. We're treating these other sensations that happen as well, functional complaints. And that's really what we're trying to do, is maximize function and limit pain so that you can live your life the way you want to live it. Primary care physicians, our PCPs really are the all-stars of our healthcare system. And why is that? It is expected that in order to manage a 2,500 patient panel, which is kind of the top end of normal for a primary care physician, but they would need almost 22 hours a day to deal with all the preventative, acute, and chronic conditions that come up. So in order to actually take care of those patients, these guys are working overtime. And that's why we have to be partners in treating patients. PCPs on average manage 3 problems per 15 to 20 minute visit. And if you can imagine how little time we have with patients, managing those 3 problems, it's not just pain that they're dealing with. There's preventative medicine, there's heart disease, lung disease, diabetes, chronic conditions that need to be managed, acute conditions, respiratory illnesses. So in order to actually manage all these things, it's extremely challenging. So that's why pain and function really, us being able to pull our weight on that side of the ball is really, really important. Clearly, it's just not enough time. There's not enough time to be able to take care of patients for our primary care physicians. So what do we do in pain medicine? Well, we do the diagnosis, we do the treatments, but we do a lot of other things too. So it's not just pain and spine and chronic pain that we deal with. I mean, we're also evaluating small joints, large joints. We're looking at the spine. We do things like radio frequency ablation. Yeah, we do things like spinal cord stimulation, peripheral nerve stimulation, pain pumps, compression fracture treatment. There's a whole wide world of what pain medicine is. And the goal, the reason we have to be so broad is because we're not just dealing with pain. We're dealing with function. We're dealing with kind of differential complaints to be able to properly optimize the function. So then the question is, when should I see a pain physician? Should I see a pain physician for just pain, or can I see a pain physician for function? If a pain physician is really a diagnostician that is managing pain and function, when's the right time? You said waiting too long was a big problem. Yeah, and that's why there are some kind of general rules for this. And my biggest one, and the thing that I talk to patients about a lot, is when our expectations don't match reality, that's when we need to start saying, okay, it's time to change the paradigm. And this is why getting a consultation, with your provider can be very, very important, because expectations of improvement after an injury, say I roll my ankle, I expect that ankle to get better in a few weeks. If it's not getting better, or if I'm not noticing improvement, maybe it's time to see about this and see if something else has happened. And typically that patient might present to a primary care physician, or maybe even go right to an orthopedic surgeon who is going to be managing a slightly strained ankle. So this is really the importance of kind of cooperative physician networking, where we're trying to handle these different issues in the smoothest way possible without overtaxing our system. The other thing, if you're not getting better, if you are not getting better, that is a time when it's important to see someone, both from pain and function. If it's weakness, get in, get seen, get someone to put their hands on you and do a physical examination. Ask for a neurologic examination. That's your right. You do not have to leave that office until you have a neurological examination ensuring full motor and sensation, okay, as well as reflexes. When you can't do the things you enjoy anymore, And this is when we talked last time about kind of the emotional affective component of pain. This is a big aspect of it. We talk about the two components of pain, what you're feeling, the sensations, and then the emotional affective component, what you have in the tank. That's really the importance of getting seen. If you're not able to do the things that you love anymore, that's really when it's time to make a change, because that's when our quality of life really depreciates. If you have severe pain rendering you nearly immobile, it's important to get evaluated, and that might even warrant being seen in the emergency department. And then if you need help navigating the healthcare system, if you need reassurance, if you need some plan so that in case something doesn't work, in case your body isn't healing itself, in case physical therapy and the conservative measures don't work, you have the ability to take care of that pain earlier. That's really when I see this as being able to reassure patients, no, your body can take care of this. I'm going to be here for you if you need it, but your body can take care of this. So that's really when we should see a pain physician. That's what we do. We are diagnosticians. We evaluate the patient and try to figure out what's going on both sides of the ball and creating a plan with the patient for functional improvement. Okay, so now we're going to talk about our anatomy spotlight. And if you're one of my patients, then you've heard this talk over and over again. I'm so sorry. But on the left, here's the spine. And on the left side of the spine is the front of the spine. On the right side of the spine is the back of the spine. The front of the spine is really the anterior column. The anterior column bears the weight, moves a little bit, but not too much. The back of the spine is really important for rotational stability. And that's really the facet joints, the bending, twisting, lifting. And really the facet joints are what we're focusing on today. These little joints on the back are what we call diarthrodial joints. They're just like knees, they're just like hips. They have a capsule, they have a synovium, and they can become inflamed. They can develop arthritis, and they can be very painful. All right. So what we're trying to do when we're doing the physical examination is figure out where's your pain coming from. When you get degenerative disc disease, like I said, the anterior column holds up the weight of the spine, and the back of the column, or the back of the spine, the posterior column, is really important for that rotational stability. When the front degenerates, it transmits more force onto the back side of the spine. This is so important because these facet joints are not meant to be load-bearing joints in the strict sense that they're not supposed to hold the axial weight of the spine up. So that's why degenerative disc disease begets or leads to problems with the back of the spine. And these things can be common as we age. And that's the importance of the physical examination, is figuring out where is the pain coming from. Like I said, there's three columns to the spine. The front of the spine, which are the discs and the vertebral bodies, the middle of the spine, which is really everything in between, and posterior, which is the back of the spine. And that's the facet joints, spinous processes, lamina, ligaments, tendons, all of those things, rotational stability. And so when we look at this, the three columns of the spine, we're really trying to figure out, okay, in terms of your axial stability, your sagittal balance, these are words to describe how the spine is functioning. Where is the pain coming from? And the reason that most of the time you can't isolate one cause of pain in the spine is because these things are connected. Like we looked at before, these are solid bones that go across. So as you have problems with the front, you have problems with the back over time. And that's really the limit of what we're able to compensate with. Now we're going to talk about facet joint injections. You guys might have heard of medial branch blocks or radiofrequency ablation. What we're trying to treat is the facet joints. We're not talking about RFA or medial branches today, but we're talking about facet joints. They're just like knees, hips, and shoulders. With repetitive wear and tear, they can develop inflammation. They can become arthritic. And then you may notice that leaning back and putting more pressure on them side to side causes your pain. We call this facet loading. But the other thing that can cause pain in the back is actually leaning forward. And that's as you might be stretching that inflamed facet capsule. So we have to think about both of these things. The other procedures that target facet joints include medial branch blocks and radiofrequency ablation. But one thing we can do is called a facet joint injection. Now, certain insurances don't let us do this anymore, which is unfortunate. But facet joint injections, we go into the joint just like we would a knee or a shoulder, put numbing medicine and some steroid. And oftentimes that's enough to calm down a lot of the inflammation. And this is a couple pictures of it. You can see that, remember that the facet joints are on the side of the spine. So this is a needle going into the facet joint with a little bit of contrast that shows that there's contrast within the facet joint and it's kind of leaking out. And that's because that joint's really small. And this is it on the other side as well. So these are examples of facet joint injections. Facet procedures, we will talk about medial branch blocks and radiofrequency down the road, but we're treating the same joints, it's just a different technique. So facet joint injections, just like a knee and a hip joint injection, medial branch blocks, radiofrequency ablation, different procedure, but to treat the same pathological process. All right, at this point, we can talk, we can take any questions if we have them. And as always, thank you guys so much for joining me. I'm out of Austin, Texas. And next week, February 23rd, we're going to be talking about defining your pain and what the importance is of when I ask you, describe your pain, and you say it's a 6 out of 10. That's not what I'm looking for. And there's a reason for that. So thank you so much again for joining me. We're going to go beyond the numbers next week, and we're going to really spend some time talking about what it means to define your pain and why we care about that definition. And I do not see any questions. But as always, I'll hop on Facebook if there are questions, and I'll try to answer those online. Thank you guys so much. If you have other things that you want to talk about that you're interested in, I have these first few planned out, but let me know as we go down the pathway. If you want to talk about spinal cord stimulation and how I approach that, great. If you want to talk about intrathecal drug delivery and pain pumps, I'll talk about that. If you want to talk about osteoporosis management, I'm happy to do that. I love talking about osteoporosis management and bone health. So thank you guys so much, and we will see you all next week.